patient in shock requires vasopressors to survive. The medication works immediately to support their blood pressure, but keeping them on that same life-saving infusion for days causes pathological organ damage. We tend to view G-protein-coupled receptors, GPCRs, as biological light switches that create fast, transient electrical or chemical changes. But extended activation reveals a completely different cellular function. Enter the G12-13 pathway. If other G proteins act as the electrical wiring of the cell, G12-13 is the heavy construction crew. It dictates long-term architectural restructuring. Looking at this schematic, the defining features of G12-13 activation are stated right at the top: remodel, migrate, and tighten. Alongside that construction power is a mandatory biological failsafe to prevent structural overload, which clinical medicine experiences as drug tolerance. To understand chronic pharmacology, we need to map the G12-13 cellular engine, apply it to 5 distinct clinical pathologies, and deconstruct that exact universal shutoff mechanism. Mastering chronic disease management means looking past acute receptor activation. You have to observe the cell's scaffolding. We start at the cellular membrane to isolate the core biochemical cascade. On this diagram, right in the center, the G12-13 heterotrimeric protein docks at the receptor. Upon activation, the G protein complex cleaves off to activate the first major intracellular target, the Rho-A protein. From there, Rho-A signals directly downstream to its primary effector, ROCK kinase. ROCK kinase executes the terminal step. It forces the assembly of thick actin-myosin bundle stress fibers, shown here cross-linking throughout the cytoplasm. In real time, this looks like thousands of fibrous cables rapidly braiding together and violently contracting, physically warping the cell's three-dimensional shape. The G12/13 pathway builds the cellular scaffolding required to alter physical shape and rigidity. Macroscopic tissue remodeling is impossible without first hijacking this precise intracellular actin-myosin engine. The clinical difference between an acute squeeze and chronic structural change is most obvious in the vascular system. Looking at the alpha-1 receptor panel, we see the standard acute response. The GQ pathway triggers immediate restriction of the blood vessel. Directly below, chronic stimulation shifts to the G12/13 pathway, resulting in a distinctly thickened, remodeled vessel wall. In prolonged shock states, continuous exposure to norepinephrine forces this exact shift. The body stops trying to acutely squeeze the vessel and instead pours cellular concrete to permanently narrow the lumen. We leverage this same mechanism pharmacologically. When we use phenylephrine for chronic vessel tone support, we actively utilize that prolonged cytoskeletal tightening to maintain blood pressure. Panning to the pulmonary system, we find the endothelin-1 molecule binding to the ETA receptor. ETA receptors deploy a dual G12-13 and GQ pathway. This combined signal drives severe scarring, clamping, and smooth muscle hypertrophy, heavily restricting the pulmonary arteries. Drugs like bosentan and macitentan are critical in pulmonary hypertension because they explicitly block this exact remodeling sequence. Treating severe vascular conditions requires halting the structural reconstruction of the vessel wall driven by G12-13. Simple vasorelaxation is insufficient. That structural power is not limited to stationary vascular tissue.
Highly mobile cells utilize the exact same mechanism to move. On the left side of the chart, in the platelet activation panel, thromboxane A2 binds to its receptor. This triggers G12/13 to force massive cytoskeletal rearrangement. The platelet physically changes shape, sprouting pseudopods to interlock and strengthen the clot. When we prescribe aspirin to prevent strokes, we are indirectly inhibiting this downstream shape change, preventing those platelets from locking together. On the complete opposite side of the spectrum, observe the immune response. Chemokine receptors activate G12/13 to force neutrophil crawling. The cell physically drags itself towards an infection using directional chemotaxis during sepsis or inflammation. The most aggressive application of this cellular motor is found in oncology and chronic disease. The physiological rule here is that G12/13 equals scar tissue and metastases. The excessive dense collagen production in fibrosis and the physical spread of cancer cells both rely on activating this exact pathway. This reveals a harsh biological economy. Whether the body is forming a life-saving clot, fighting an infection, or succumbing to a tumor, it hijacks the exact same Roe rock mechanical engine to physically move cells. This raises a critical biological tension. If chronic agonism drives massive, permanent structural changes, how does the cell protect itself from lethal overstimulation? It uses homologous desensitization, a universal, self-preserving feedback loop designed to mute a signal that refuses to stop. We can trace this in the safety shutoff diagram. In step 1, repeated agonist stimulation hits the GPCR over and over. Moving to step 2, the cell detects this overactivity. An enzyme called G-protein receptor kinase, or GRK, arrives and phosphorylates the intracellular tail of the receptor, tagging it.
Recognizes those phosphate tags. It binds directly to the receptor, acting as a physical padlock that blocks any further G-protein coupling. The internal signal is cut. Finally, in steps 4 and 5, the cell initiates endocytosis. The silenced receptor is physically pulled inside the cell membrane. The total number of surface receptors drops, permanently weakening the tissue's response to the drug. This exact sequence explains why an asthmatic develops tolerance to salbutamol. It dictates why ICU patients require escalating vasopressor doses. It is the exact reason opioid receptors become tolerant to fentanyl, and why prolonged use of oxymetallazine causes rebound nasal congestion. Clinical drug tolerance is not a failure of the medication. It is the flawless execution of the cell's GRK and beta-arrestin safety protocol. Bringing the entire schematic back into view, the relationship between structure and tolerance becomes clear. On the top and left, we have the builder. The G12/13 pathway utilizes Roe and ROCK to force cytoskeletal shape changes, driving migration, fibrosis, and prolonged contraction. On the bottom right, we have the regulator. GRK tags the receptor, beta-arrestin blocks it, and internalization hides it, causing tachyphylaxis and tolerance. Modern clinical pharmacology requires managing both sides of this equation simultaneously. You are constantly balancing the structural drive of the drug against the desensitization protocol of the cell. Mastering these dual mechanisms reveals the mechanical cellular logic beneath the chaotic presentation of chronic diseases and drug failures.